Breast cancer during pregnancy, diagnosis and management. Breast cancer occurring during pregnancy presents unique clinical challenges due to physiological changes and treatment constraints. This comprehensive review explores detection, diagnosis, and evidence-based management strategies. Understanding breast cancer in pregnancy. The diagnosis of breast cancer during pregnancy represents a significant medical challenge that requires coordinated care between obstetric and oncologic specialists. Breast cancer in pregnancy, sometimes referred to as gestational breast cancer or pregnancy-associated breast cancer when diagnosed within 1 year of delivery, occurs in approximately 1 in 3,000 pregnancies. This relatively rare occurrence creates diagnostic complexity because pregnancy-induced physiological changes in breast tissue can obscure malignant lesions and delay detection. Understanding the unique presentation and management of this condition is essential for healthcare providers managing pregnant patients with suspicious breast symptoms. Physiological changes complicating diagnosis. During pregnancy, the breast undergoes substantial morphological and functional changes in preparation for lactation. These changes include increased glandular proliferation, tissue density, and vascular engorgement, which can make identifying abnormal masses considerably more difficult. The increased fluid content and hormonal stimulation of breast tissue during pregnancy may mask or mimic malignant lesions, leading some clinicians to initially dismiss concerning symptoms as pregnancy-related. Additionally, pregnant patients may normalize breast symptoms as part of normal gestational changes, potentially delaying their presentation to healthcare providers. The combination of these physiological alterations and patient factors frequently results in delayed diagnosis, which can affect prognosis and treatment planning. Clinical presentation and symptom recognition. Recognition of warning signs is crucial for early detection in pregnant patients. While bilateral breast tenderness is typically benign and associated with hormonal changes, pain localized to a specific region warrants investigation, particularly if accompanied by other concerning features. The presence of a hard mass, whether discovered by the patient or during clinical examination, should never be attributed solely to pregnancy-related changes without appropriate diagnostic workup. Nipple discharge, especially when unilateral and spontaneous, represents a concerning symptom that requires immediate evaluation. Healthcare providers must maintain a high index of suspicion during pregnancy and refrain from dismissing breast symptoms as purely gestational phenomena. Key points: localized breast pain or discomfort concentrated in one area of the breast, particularly when accompanied by a palpable mass. Discovery of a discrete, firm breast mass that does not fluctuate with the menstrual cycle or pregnancy progression. Spontaneous or persistent nipple discharge, especially if bloody, clear, or unilateral. Skin changes including dimpling, retraction, or unusual texture that does not resolve with position changes. Diagnostic imaging approaches. Establishing a diagnosis of breast cancer during pregnancy involves carefully selecting imaging modalities that provide diagnostic accuracy while minimizing fetal radiation exposure. Clinical breast examination remains the essential first step and should be performed systematically and thoroughly. When imaging is indicated, ultrasonography represents the preferred initial imaging modality because it provides excellent visualization of breast tissue without ionizing radiation exposure to the developing fetus. Ultrasound can effectively differentiate between benign lesions such as galactoceles or adenomas and suspicious masses requiring further investigation. Mammography may be performed during pregnancy when ultrasonographic findings are inconclusive or when additional imaging information is needed for treatment planning. Modern mammographic techniques with abdominal shielding result in minimal fetal radiation exposure, while below the threshold considered teratogenic. Magnetic resonance imaging offers another valuable diagnostic option for pregnant patients, as it provides detailed anatomical visualization without ionizing radiation. MRI proves particularly useful for determining the extent of disease, identifying multifocal or bilateral involvement, and assessing axillary involvement. The choice of imaging modality should be individualized based on clinical presentation, ultrasonographic findings, and the specific information needed to guide treatment decisions. Tissue diagnosis and pathological confirmation. Definitive diagnosis of breast cancer requires tissue sampling and histopathological examination. Fine needle aspiration cytology and core needle biopsy represent appropriate diagnostic approaches during pregnancy, as both procedures can be performed safely with ultrasound guidance. Core needle biopsy provides superior diagnostic accuracy compared to fine needle aspiration and is preferred when feasible. These minimally invasive procedures carry minimal risk to the pregnancy and provide adequate tissue for pathological evaluation, immunohistochemical analysis, and molecular testing. Excisional biopsy should generally be reserved for situations where needle-based diagnosis has been inconclusive, as it involves greater tissue manipulation. Staging considerations during pregnancy. Accurate staging determines prognosis and guides treatment planning. Chest radiography with abdominal shielding can be performed safely to exclude pulmonary metastases. Conventional bone scintigraphy and CT imaging of the abdomen and pelvis carry greater fetal radiation risks and should be avoided unless absolutely essential for clinical decision-making. Abdominal ultrasound can assess hepatic involvement and evaluate for ascites. The primary goal of staging during pregnancy involves determining whether disease is localized to the breast and axillary lymph nodes or whether distant metastases are present, as this distinction fundamentally impacts treatment recommendations. Many pregnant patients with newly diagnosed breast cancer will have localized disease amenable to curative treatment. Treatment options and fetal considerations. Treatment planning must balance maternal health and disease control against fetal safety and developmental outcomes. Surgery represents the safest treatment modality during pregnancy and should generally be the first component of multimodal therapy. Mastectomy or breast-conserving surgery with sentinel lymph node biopsy or axillary dissection can be performed safely throughout pregnancy, though many surgeons prefer to defer elective surgery to the second trimester when fetal organogenesis is complete. Chemotherapy administration during pregnancy, while initially concerning to many patients, has been studied extensively in published cohorts. Chemotherapy, particularly regimens containing alkylating agents and anthracyclines, can be administered during the second and third trimesters with acceptable fetal safety profiles when balancing risks and benefits. The first trimester represents the period of highest teratogenic risk due to ongoing organogenesis, and chemotherapy is generally avoided during this period unless absolutely necessary. Radiation therapy directed at the breast and regional lymph nodes carries potential fetal risks and should be deferred until after delivery whenever feasible. Hormonal therapies such as tamoxifen and aromatase inhibitors have less established safety data and are generally avoided during pregnancy. Targeted therapies targeting HER2 overexpression require individual risk-benefit assessment and specialist consultation. Delivery planning and peripartum management. The timing and method of delivery should be individualized based on the stage of pregnancy at diagnosis, maternal disease progression, and obstetric factors. Most pregnant patients with breast cancer can be allowed to progress to term or near term, though some may require earlier delivery to complete cancer treatment. The mode of delivery, whether vaginal or cesarean, should be determined by obstetric indications rather than cancer-related factors, unless specific circumstances such as local chest wall involvement contraindicate vaginal delivery. Patients receiving chemotherapy near-term may require delayed delivery to allow adequate bone marrow recovery and minimize neonatal exposure to active chemotherapy agents. Postpartum treatment continuation. The postpartum period allows completion or initiation of treatments deferred during pregnancy. Radiation therapy can proceed safely after delivery, though timing should account for any continued chemotherapy administration. Patients who nurse during pregnancy should discontinue breastfeeding before initiating certain medications and treatments. Hormonal therapy with tamoxifen becomes a viable option after delivery and breastfeeding has ended. The postpartum period also represents an important time for assessment of disease response and evaluation for any progression that may have occurred during pregnancy. Psychosocial support and counseling. The diagnosis of breast cancer during pregnancy carries substantial emotional and psychological burden for patients and their families. Comprehensive care should include access to mental health professionals experienced in oncology and maternal health. Genetic counseling becomes important for patients with early-onset breast cancer, as pregnancy may not be the appropriate time for extensive genetic testing or risk-reducing interventions. Multidisciplinary team meetings involving obstetric and oncologic specialists, nursing staff, social workers, and other support personnel facilitate coordinated decision-making and comprehensive patient education. Support groups specifically designed for pregnant patients with cancer can provide valuable peer support and practical resources. Long-term prognosis and outcomes. Prognosis for breast cancer diagnosed during pregnancy depends primarily on tumor characteristics, stage at diagnosis, and completeness of cancer treatment rather than pregnancy itself. Published studies demonstrate that appropriately treated pregnant patients with localized breast cancer achieve survival outcomes comparable to non-pregnant patients with similar tumor biology and stage. However, pregnancy-associated breast cancers are sometimes diagnosed at more advanced stages, potentially reflecting diagnostic delays. Long-term follow-up studies indicate that continuation of pregnancy does not compromise maternal survival when appropriate treatment is provided. Most women diagnosed with breast cancer during pregnancy who receive definitive treatment go on to achieve remission or prolonged disease-free survival. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.